Good afternoon. I am Dr. Doug Evans, Chair of the Department of Surgery at the Medical College of Wisconsin, and welcome to our weekly update on programs in the department and innovations that we feel will be of great interest to all of you. Today I'm lucky enough to be joined by Dr. Tim Ridolfi. Tim, welcome and thanks so much for joining us. Tim is a specialist in colorectal surgery and certainly colorectal cancer, which is the topic of today. He is a graduate of the University of Wisconsin, went to medical school here at the Medical College of Wisconsin, where he then stayed for his surgical training to include a couple years of dedicated laboratory research. He then completed a fellowship in colon and rectal surgery at the Cleveland Clinic before returning here to join our faculty. And if any of you have heard me talk about the importance of research on one of our other videos, one of the ways I try to frame this, Tim, is our commitment and our dedication to not only the patient of today, but also the patient of tomorrow. If you can think about it for a minute, if we only used the available technology of today, in 5 or 10 years, we may be doing things more efficiently, perhaps a little bit less expensive, but we would not have any innovations in drug delivery, in surgical technique, in use of new modalities of treating disease. And so the patient of tomorrow would not experience the advances that are needed to really improve our treatment of all human diseases. Obviously, our topic for the next few minutes is rectal cancer. While Tim is going to talk a little bit about research as we move along, maybe you can introduce the topic of rectal cancer a little bit, and especially why this has been such a hot topic in the news, be it the newspaper or on the TV, et cetera, recently.
All right. Well, thank you for having me. Yeah, there has been a lot of information about rectal cancer recently that's been on the news. Probably the biggest reason for that is that new study that came out from the American Cancer Society that looked at patients with younger diagnosis of colon and rectal cancer. And there's been a startling finding that those that have been born in the 1990s actually have a 4-time increased risk of rectal cancer and twice the increase of colon cancers as their older counterparts. So there's a great concern that that actual increase will actually follow those group of patients along throughout their years. And as you can imagine, there's a big, great importance in trying to not only figure out why that is occurring, but also helping to improve the kind of care that those patients are receiving, especially rectal cancer patients, as so many of them are young patients.
Well, certainly, I often view colon and rectal cancer as a truly preventable disease because, and you can correct me if I'm wrong, virtually all cancers start out as a little polyp or a little abnormality in the colon, so that if one gets a colonoscopy and the abnormality is removed through the scope, theoretically, it should not be able to develop into a cancer. Maybe you can comment on, is that logic correct? And if so, when should individuals get their first colonoscopy?
Yeah, by and large, that is correct. So the idea that small polyps will eventually turn to cancer or have the potential to turn to cancer is absolutely correct. And that's the whole idea and premise why screening colonoscopy works. So patients that are age 50 or have a first-degree relative that has had a diagnosis of colon or rectal cancer should have a colonoscopy 10 years prior to that. And by and large, when those polyps are found, colon cancer can be prevented as well as rectal cancer can be prevented from occurring. So it's extraordinarily important for patients to undergo those screening studies at those age points.
So basically, if you have a family history, age 40,
well, 10 years earlier than the diagnosis of the first-degree relative that had a cancer. So, for instance, if a first-degree relative had a cancer at age 50, your screening colonoscopy should be age 40. Okay. If that person was age 40, yours should be as early as age 30. But it's very important, especially those that are young, that they do not fall within the normal screening guidelines. So anyone with that's experiencing changes in bowel function or bleeding should definitely be considered for having a colonoscopy as well to figure out what the cause of those situations are.
You know, when I talk to patients, and certainly as someone who has had a couple colonoscopies already, The procedure itself is relatively innocuous. You typically get a touch of sedation, and you doze off, and wake up in a little bit, and it's all over. It really is a painless procedure. What everyone complains about is the bowel prep the day before. So in order for the surgeon or gastroenterologist, whoever is doing the procedure, to actually get a good look at the colon, it has to be clean, and so therefore one has to take medication or liquids to empty out the colon. Is there any progress being made in making that bowel prep a little bit more tolerable, which theoretically, I suppose, would encourage more people to have a colonoscopy?
Yeah, there's been a lot of discussion revolving around bowel preps. You're exactly right. The procedure itself is really well tolerated, extraordinarily safe, or we wouldn't offer it to so many people as a screening process. The portion of the bowel prep, really, the safest bowel prep out there is really the standard bowel prep, which is a large amount of fluid that's drank and essentially cleanses the entire GI tract and colon. There were some formulations of bowel prep in the past that did allow for a little smaller volume, but those were found to have a bit of electrolyte abnormalities, so those are no longer on the market. But there are some slightly less amount of volume preps that are out there that can be offered. But by and large, so the standard bowel prep is a large volume bowel prep.
Great. Well, we may focus the rest of this video on the patient of tomorrow. Dr. Ridolfi is one of our physician scientists, which means that his life here at work is divided into both a dedication and commitment to the patient of today in his clinical practice, and an intense devotion to the patient of tomorrow with his research focus. Maybe you can talk a little bit about the research that's going on here at the Medical College of Wisconsin, and update our viewers on what you're doing and what others are doing.
Yeah, so the majority of projects that we have currently within the division of colorectal surgery at the Medical College of Wisconsin here revolve around rectal cancer. And like I said earlier, we really are looking at how to improve the quality of care and actually improve the aftermath of the kind of situation that the patient is dealt with after having their rectum removed for a rectal cancer. So one of the areas that we have intense focus on is looking at how patients' bowel function changes after resection of the rectum. So often after a diagnosis of rectal cancer is made, there's an element of treatment that has to occur with radiation and chemotherapy. That is then followed by a surgical resection. After the rectum is...
So the rectum is removed, and then typically, in most cases, the colon is hooked back up again. So a segment is taken out and the plumbing put back together again. The patient still moves their bowels the regular way, albeit they're missing a segment of intestine.
Correct. So the bowel movements continue to come through transanally as they have in the past, but the function of the bowel is a little bit different as the rectum has been removed. Some patients actually fare quite well and don't quite have much difficulty. Other patients, unfortunately, have quite a bit of clustering of bowel movements, frequency of bowel movements, urgency, and some elements of incontinence. It's been a little bit of a mystery as to why some patients have that and other patients do not. And actually, over a period of up to almost 2 years, patients can develop a decrease in those symptoms. So there's some type of adaptation that's occurring. What we've been trying to sort out in our basic science lab, as well as in the clinical realm, is why that is occurring and if we can change how that is occurring or potentially prevent it from occurring at all. So what we've seen in the basic science lab is that there are some type of receptors that lie within the colon that can be changed after the surgery is done. We've now taken that to the next step and looked to see if that's actually occurring in our patients. So we're in the very initial phases of looking at actual biopsies from human colon tissue to determine if those exact changes are occurring and if we can correlate those to the amount of dysfunction that a person is having. If we can make those correlations, there are medications that can be used to kind of reduce the effect that this upregulation of receptors might be having. So in the bottom line is that if we're able to show this, we may be able to improve how patients are feeling after the surgery that would be necessary for them.
Yeah, great. Maybe you could talk in closing just a few minutes on how is research like this supported and how is it funded? I know that there's always something in the newspaper or on TV with regard to research funding. It usually varies in proportion to how the economy is doing, what the attitude of the government is, but certainly with medicine being very expensive overall in this country, certainly the research budget is often one of the first to take it on the chin. How are you navigating those difficult waters and ensuring that, and your research is so clinically important. I mean, you can imagine that if you could find a technique, a new drug, a combination of surgery, drugs, et cetera, that could ensure that patients would have completely normal function after removal of the rectum and a portion of the colon, that would be game-changing with respect to the field of colorectal surgery and colorectal cancer management. But how do you support this effort?
In order to do that question justice, I should also highlight a couple other projects too that are happening in the division. Another project that we're having is that we're kind of part of in our division is one that's actually sponsored across a network of hospitals through an alliance, if you will, and it is called the Prospect Trial. In that trial, we're also seeing if there's a certain segment of patients that can not be subjected to radiation, as it comes with some elements downsides as well. And there's another trial that we're actually part of too, or that we're instituting here, that looks at the changes of the rectum in how it looks at in a 7 Tesla MRI, which we're fortunate to have one of, which are only 20 worldwide. That project is actually very exciting in that we're trying to determine if we can find a particular small subset of patients that actually have a complete response to chemotherapy and radiation prior to needing a surgery. And there's been some work, especially out of Brazil, looking at maybe the patients that have a complete response to a little therapy up front of chemotherapy and radiation may not require a surgery at all, which, as you can imagine, would make the function that those patients have much, much better after surgery.
Sure.
So if you think about all that various degree of research and the different levels that it takes, there's a lot of different ways that it's funded. I'm lucky enough to be the recipient of one of the Career Development Awards for the American Society of Colon and Rectal Surgeons. That's kind of a national funding level. We also have the project that we're looking at the 7 Tesla MRIs for rectal cancer is in large part funded by funds that are received through an annual local walk-run called the Get Your Rear and Gear event here. And the Alliance trial actually is part of the clinical trials office at the Cancer Center, and that was in part funded by one of the grateful patients that we've had here. So it's a large degree of philanthropy, as well as local funds that are coming, and as well as national funds. So there's a lot of different degrees of funding lines that are happening.
You mentioned your Career Development Award, and I'll just end with maybe a few words on colorectal surgery as a subspecialty. For those people who don't know, colorectal surgery is now a separate board-certified specialty. So Dr. Ridolfi is not only board-certified in general surgery, but also in colorectal surgery. And I think this area has evolved due to the realization that certainly the area of the rectum and anus, as well as probably the whole field of inflammatory bowel disease, are just such unique entities that require just a constant level of thought, consideration, advanced training, and focus. And certainly for those patients who are unfortunate enough to have a problem that certainly involves the lower part of the colon, the rectum, and the anus, I think there's a tremendous amount to be said for seeing someone who has devoted their entire life to a colorectal surgery. I don't know if I'll give you the final comment, Tim, on this.
Yeah, I mean, I think that's absolutely true. You know, to go on and have the additional training to specialize in the anatomy of that region, which is highly complex, especially in the pelvis, given all of the structures that are in really close proximity, the degree of change that it imports on someone's life, having a part of their intestine removed, resected, and also the additional training of, especially in the world of rectal cancer, sphincter-sparing techniques,
Sure.
meaning doing everything we possibly can to avoid the need for a permanent stoma. Unfortunately, that is at times required, but we take it, we take it very, very strongly upon ourselves as a challenge to always try to restore normal intestinal continuity. And I think that
so a huge part of your training and your practice is trying to avoid a colostomy, or as the non-medical person would say, moving their bowels into a bag and allowing them to not have anything different on their outside of their abdomen other than maybe a few scars, but at least move their bowels the same way, correct?
Exactly. And I think that that's part of the additional training that we have, that we're much more likely to achieve that kind of a result.
Great. Well, Tim, thank you very much.
My pleasure.